to Dr. Giacono, when you're restaging or staging a myeloma patient, maybe smoldering myeloma, are you doing PET scans or are you doing dedicated MRIs? And if you do the latter, how do you send it to radiology? What do you do?
This is for a smoldering myeloma patient?
Staging the patient.
Yeah, so smoldering myeloma, definitely skeletal survey is not adequate because even the definition of how you call a patient smoldering depends upon higher level of imaging. But I got to tell you, I'm in the same town as you, and we all have the third-party payers. You try PET-CT. If it is not approved, you go for MRI of the spine and pelvis. So I don't think it is any different when it comes to the practice. But you got to get one higher level of imaging. That's for sure.
In our practice, we use MRs. We actually use whole body MRs, but I think if you use spine and pelvis, that's okay as well. The rationale for that being that it's got a lower sensitivity of you can detect a 0.5 centimeter focal marrow lesion, and because that's one of the number of focal marrow lesions has now become one of the myeloma defining events. This is sort of our go-to study, at least in the smoldering setting.
When I speak to Dr. Jagannath and ask him about whether a transplant should be done, it's sort of like asking a carpenter, should you make cabinets? But what I want to ask you is, I think we're all convinced that when you do an auto transplant, you should do it up front. There is an advantage. But is that advantage strictly because you can get a deeper MRD? If you could get the same MRD without using a transplant, would you need to do the transplant, particularly in this era where we're going to bring daratumumab up front? In other words, my personal feeling is, and I think there are data to confirm what I'm saying, is that the reason transplants work is that you get more MRD, you get a greater depth of response. But if you could do that with drugs, do you really need the transplant?
I think yours is a rhetorical question with the answer already built in your statement.
Well, thank you for agreeing, Dr. Jagannath.
I'll let a younger colleague handle
Yeah, I was
that.
going to say, I'm going to be the young punk on the block here and say that I don't think we really know whether or not transplant adds to somebody who's already sort of MRD negative by our current assays. I think it really depends on how deep down in the iceberg you're looking in terms of MRD. Certainly, there is data from the IFM study that Dr. Jagannath mentioned where they did look at MRD, and the individuals that achieved MRD, at least with the short follow-up that's been reported today, did just as well, irrespective of which treatment arm they were on, whether they got the transplant or not. But I think that that's really a great study question. If you're MRD negative after induction, should we just randomize whether you go to transplant or not and actually formally ask that question? I don't think we know the answer.
I have a slightly different answer. So, one of my first slide was that multiple myeloma has multiple clones, and I believe different clones respond very beautifully and can be eliminated by different drugs. So I do believe melphalan residues. But if you are able to eliminate it by MRD level, using multi-parameter flow cytometry or at Memorial 8 color, or you send it, in that particular patient, it is clear that whatever drugs you used was quite effective. The patient was not left with minimal residual disease. So the transplant need not be utilized there. But if the patient was not in that situation, I believe switching another class of drug may eliminate another subset of population which was not necessarily sensitive to proteasome inhibitor and immunomodulatory molecule. And in the future, we'll have the antibody. It will be 4-drug treatment. So in that subpopulation, I think the transplant. So we may be able to parse it as these technologies actually come into our clinical practice. So which was in a way what you alluded to. But the second part of it is early versus late transplant. The problem is the very patients who did not want the transplant up front, these are the very patients who will say, oh, now there are more drugs. Can I get the antibody or something for my relapse? So they don't necessarily go for the second transplant. So every early versus late transplant, you will never be able to show 80% of the patients who deferred transplant actually ended up getting the transplant. It will always drop below 60%. So it never comes out to bear to fruition that the later transplant comes out ahead of the earlier transplantation.
And just one quick question. I'm surprised that they're using BCMA for the target for CAR T, since there's a fair amount of circulating BCMA that might negate it. Why didn't they use CD38 rather than BCMA?
Well, I think CD38 is much more broadly expressed on
Like red cells.
red cells, T
Yeah.
cells, epithelial cells. So BCMA is a much more specific target. But I think the questions always come up about circulating BCMA, and I think that that's just something that's going to need to be studied to understand its impact.
And how much that does, and will that cause cytokine release and some of the toxicities or not? You know, because if it does react to it, does it activate the T cell or not? Still can be. Yes,
Just a
Dr.
practical question about, what do you ask the blood bank specifically before starting DARA about what to do and after and when they need to be transfused, et cetera? Just practically, how do you deal with the blood
Yes,
bank?
we always send, it's part of the order set, that before the chemotherapy is infused, the blood is drawn and sent to the blood bank, and they are notified this patient is on daratumumab. It's already built into the order
I
set
know,
so
but-
that they don't make a mistake.
Well, that's the bureaucracy, but what do they actually do?
What the antibody does?
Do you know what the blood bank
Well,
does?
Yeah, they just type and cross. So they just type them so they know what it is. That's what the blood bank does. It just
So
types
you
and cross
just
so you
ask
know it
the
before.
blood bank to type and cross the patient before getting DARA?
So, I mean,
Correct.
And you don't have to do anything else?
Correct.
So our-
Now, the challenge comes, and they may tell you, is that if you type and cross them, you're fine, you know what antigens they have or not.
Right.
What happens is if all of a sudden they need repeated transfusions.
Right. That's what I'm-
And then you block it, that could be a challenge. So, but that's what, but there's, again, then you have to do some of the negating antibodies and that other things to do it.
Yeah, it gets complicated.
Correct.
Maybe.
It does, but just in the front, you just need to get them
Okay.
to type and cross. So you say this, they're A negative and they have these, antigens, and so they would basically be able to get
Compatible blood. Right.
to do it if they need transfusion.
So, I mean, our blood bank initially started out doing an antibody workup for patients after the daratumumab infusion, and I don't want to misstate what the blood bank director has told me, but I think he's figured out some of the reagents to overcome it.
Yeah, there is a new technique that
Yeah.
arises.
But I don't know the specifics of the technique.
But I think they can neutralize the CD38 and then be able to do a screen. So, but that's probably something that if you need it, but that's really going to be those patients who require multiple transfusions after they've been on it. And not a lot of patients on DARA will require it, but yes.
Somebody who is IgG kappa myeloma and they get DARA. Now, if I were to follow IgG, you mentioned there is an assay to be done. Is it commercially available or?
So it's been used in clinical studies. Do you know if it's commercial?
No. So you can follow the IgG.
Yes.
The immunofixation will never disappear.
That's right.
And for clinical trial, if you want to know whether the patient is really in complete remission or not, then the immunofixation in an IgG kappa myeloma, because the monoclonal antibody is IgG kappa, you may still get the ban. But patient, once they go down to once a month and further down the line with that, you may still get it. But it is totally for clinical trial so that the drug companies are fretting it out that their CR rate could be higher, IFE negative, because some of them are not, they are VGPR because we don't think VGPR. But it comes to only IgG kappa. Granted, IgG is more common than IgA, only IgG kappa. At the bedside, to me, once I know the IgG came down from 3 grams to 1,000, I'm very happy. It really doesn't matter to me.
The other thing is a bone marrow assessment, it will obviously answer the question.
Yes.
So Sundar, practical question. The DARA has, in the community has been, used quite widely, but the ELO, I think, has kind of fallen behind. So where do you see its use? Just after 1 or 2 failures, or you use it down the line when there are like 4 or 5 treatment failures? Can you use it at that time and see responses, or you kind of feel that DARA is the right drug to choose in that setting?
My personal bias is that daratumumab had monotherapy activity, much more potent. Ilotuzumab had no monotherapy, but it was good for patients with high risk, etc., when it was given with Lendex. So my patients who are going on maintenance therapy, I try to use it around that time. And if an insurance wouldn't pay for it at that time, the earliest sign of relapse, when you would normally add dex or increase the dose of lenalidomide, at that time I'll go with the elotuzumab. Once the patient is multiply relapsed, I go more for DARA rather than going for the ELO. PALM and ELO is also workable, so IMID, whether it is lenalidomide or not, is not the key. But I feel like the DARA is much more potent than ELO. So the clinical scenario, slow relapse, maintenance therapy, those kind of areas where I choose ELO with an IMID molecule.
So lenalidomide maintenance rescue situations, I completely agree. This is where I use it. And the other place I use it is in the individuals that balk at long infusion times. Some people actually have issue with that. So I would use it in that situation.
Thank you.
Okay. So thank you all. Actually, I want to just thank everybody. It's been a great discussion. I think we've had a